Hello, everybody, and welcome to Hughes Clues Treatment Modalities. Before we begin this recording, or before you begin listening to this recording, it would be helpful if you found the document entitled Emergency Treatment of Lethal or Unstable Dysrhythmias. It should be within the same grouping as this PowerPoint, and it's also found in our supplement. I'm not sure where it is or how it's written in Dr. Reed's Blackboard organization, but again, the title of the document is Emergency Treatment of Lethal or Unstable Dysrhythmias. This is something that you need to know like the back of your hand, and you don't necessarily have to memorize it. You can go ahead and put it on your exam sheet, but it's very, very important that you know this information. Now, let's begin with some patient scenarios. So you've got two patients that you're caring for in the emergency department or in the critical care unit, whichever you'd like to be in. And one is admitted with an inferior MI. That's this guy on the left here, and he's returned from the cardiac cath lab and his chest pain's resolved. And then the other patient has been admitted also with an inferior MI, and he's got complaints of dizziness, feels like he's going to pass out. And look at his blood pressure and oxygen saturation. So when you look at this rhythm, both of them are presenting with this rhythm. So should you, the nurse, intervene? Should you do something about this? And so that brings us to some considerations with any rhythm. Any abnormal cardiac rhythm can present or can cause the cardiac output to go down. And so the key things you want to ask yourself as you assess your patient, is the patient symptomatic? And symptomatic would mean, are they having chest pain or dyspnea or dizziness or diaphoretic cool clammy or palpitations? And if they appear to be not symptomatic, then you might consider observing, or if they are symptomatic, you might consider treating. The other thing you have to ask yourself is the patient hemodynamically unstable? And if you go back or try and remember what the original scenario was, when we look at the patient that was on the right, this was the patient that was in a first-degree AV block that is bradycardic. When you look at this patient, he's complaining of dizziness. He feels like he's going to pass out. So those are some symptoms that he's having. But his BP is 80/40. And so this is an individual who is hemodynamically unstable. And so the treatment protocol may be a tad bit different for somebody who is hemodynamically unstable and symptomatic than that individual who is really bright-eyed and just looking at you and is not complaining of any problems. So you look at their level of consciousness, their oxygenation, their pulse, their pulselessness, if they have again, if they have symptoms and they are hemodynamically stable, then you may just observe them, or they may need some slower treatment such as IV push medications. Whereas the individual who is not only symptomatic but who is also hemodynamically unstable, then you're going to have to treat that patient very quickly. You're going to have to do some things that might lead to a faster treatment of that ribbon. And one of those things is the use of electricity. Now, there's two different ways that electricity can be used, and they're known as synchronized cardioversion or defibrillation. Now, both of these methods, whether it's cardioversion, synchronized cardioversion, or defibrillation, use electrical energy to reboot or restart the heart. In other words, whenever your computer is acting up, when it's not functioning well, a lot of times you have to turn it off, and then the hope when you restart it is that the computer will then work properly. So it's the same thing with the heart. When we use either synchronized cardioversion or defibrillation, we are providing or giving the patient electricity, and the hope because when you deliver this electrical impulse, the heart will stop. They'll go flat line. And then the hope is that the SA node, which is the heart's natural pacemaker, will begin working normally. So they'll go back to some kind of normal rhythm. Again, how do you or when do you use synchronized cardioversion versus defibrillation? So synchronized cardioversion is used when the patient has a pulse. Usually there is a lower amount of energy that is used, and again, you're not tested on how much energy should be applied. That is a physician prescription. However, to perform a synchronized cardioversion, you must hit the synchronized button. Now, you might say to yourself, well, I don't have the whole monitor or the defibrillator machine memorized, so I'm not sure. So you need to go to this YouTube site and look at the monitor, or when you're next on your ICU rotation, go look at a monitor so that you can hear. But you have to hit the synchronized button if you're going to do synchronized cardioversion. Once the synchronize button is pushed, then you're going to see either spikes or a dot or some kind of arrow that's going to find the R wave. And what that does is it's kind of like an X marks the spot. It is a way for the machine to know, well, this is when I need to hit the patient with the electrical charge, because we want the electricity to be delivered during depolarization, when the heart's actually working. Because if the electricity from the defibrillator was actually delivered and it landed on the T wave, that's during repolarization or when the ventricle is resting, then you can actually send them into a lethal rhythm such as VFib or VTAC. And so again, I encourage you to go watch that YouTube video before you email me a question about synchronized cardioversion. And then I also have another one for you on defibrillation. So watch these videos before you email questions about defibrillation, and then feel free to do so. Now, when do we use defibrillation instead of synchronized cardioversion? So that's used when the patient doesn't have a pulse, because if they don't have a pulse, the ventricle's not really working or resting. It's not doing anything but either quivering or not functioning. So usually with defibrillation, a higher amount of energy is used, and we don't care when we need to deliver the shock. So these are the differences between synchronized cardioversion and defibrillation. Now let's talk about the treatments when we have the different rhythms. And I know it's kind of overwhelming. You have 14 rhythms that you must know, because at least 4 or 5 of them will be on the exam. And so let's look here first. We've got a man that presents with dizziness. He feels like he's going to pass out. His blood pressure is 80/40. Oxygen saturation is 98%. And then I've got a strip there in front of you. So pause the recording and then try and answer the questions that I have put in front of you, and that's identifying the rhythm. Is the patient symptomatic, hemodynamically unstable? And then try and figure a treatment. Again, you can use that document that I told you to have at your hand whenever we started this recording. So let's look at this. So first we identify the rhythm as first degree AV block, and the rhythm is rather slow also, which is very, very typical of any kind of block. Is the patient symptomatic? Well, yeah, he's dizzy and he feels faint and he's not hemodynamically stable. He is hemodynamically unstable. His blood pressure is low. And so what treatment might be deployed for this gentleman? Well, we can give atropine at 0.5 milligrams IV push. Again, I've kind of summarized for you what you should have as far as what treatments are initiated. And again, you're not responsible for the dosing of medications, but just be aware, because you may actually have a patient with this rhythm, that you can re-administer atropine to a total dosage of 3 milligrams. And the reason why I've put these 3 rhythms here, the top one is sinus bradycardia, the next one is the one we just looked at. That's first degree AV block. And then that third rhythm here is Winky-Bach. This is second degree Mobitz type 1 or Winky-Bach. And all of these rhythms are likely to be treated with the same treatment, and that is the administration of atropine. And again, I say know all the treatment recipes well. Again, you don't have to memorize this. You can put this down on your exam sheet. And what I ask you to do, or what I think is a good idea to do, is make your own flashcards. You cut and paste the strip on one side and then place the treatment on the back. And that's just one way to learn these rhythms. I know, again, that you're very busy. This exam 2 is an overwhelming amount of information. I know this is extra work for you, but I know you want to do well on this exam. Let's do another scenario where a man presents with dizziness, feels like he's going to pass out. You've got his vital signs there, and atropine has already given to a total of 3 milligrams. So there's no change in the rhythm, or the condition of the patient. So again, identify the rhythm, identify the other questions, and then figure out, well, what treatment should be utilized for this individual. And when we look at this rhythm, we can see that this is second degree AV block Mobitz type 2. So in the grand scheme of triage or prioritization, we would say that sinus Brady, first degree AV block, and second degree AV block Mobitz type 1 or Winky block are probably less lethal or less likely to need advanced treatment, though they can. It just depends on the overall consideration of what's happening with the patient. But when you get into the second degree AV block Mobitz type 2, then this is getting into a typically more lethal rhythm for patients. And this patient, if we just keep going with our scenario, he is symptomatic and he is hemodynamically unstable. So if you've reached the max dose of atropine, or if the patient is truly very unstable and you don't even want to mess around with atropine, which is a physician's prerogative, then it's time to initiate pacing of the patient. And to recall that pacing, there are 3 different methods: transcutaneous, transvenous, and epicardial. Again, these things often happen at 2 or 3 in the morning when there isn't a physician around. And so transcutaneous is your fastest and easiest method to pace a patient. Now, often students tell me, you know what, I just don't get this whole which bradycardia, which block it is. They look very similar. They're difficult to identify. And so this is the thing I want to reassure you. It really doesn't matter. I mean, if you know that the rhythm is slow, and that it is either some kind of block or some kind of bradycardia, if you look here, all the treatment is the same. So SB, sinus brady, or any of the AV blocks, the treatment's the same. And because you guys are often have to deal with the select all that apply questions, well, you may have to know all the treatment for any of them. So you can be readily the information is readily available. You just pick one of these things if you know it's a bradycardic and it's either a sinus brady or an AV block. Now, I'm not saying to you that, wow, it's not that important to identify the different rhythms, because it is, but you're just trying to get through this course right now. Once you become a critical care nurse, you're going to have to be a lot more discerning and identify the different blocks. But for right now, you want to just get through this. And if you're a OB person or a pediatric person, you don't have to deal with these kind of rhythms. So just pass the course. So again, if this individual has a third degree AV block, which is what this rhythm is, then the treatment really should be almost first line pacing. Now, let's move on to a different kind of rhythm, and that's a nursing student that presents with palpitations. She's been up all night studying for a critical care exam and drinking Red Bull. I feel like my heart's about to jump out of my chest, and there's her vital signs. Can any of you relate to this scenario? We're going to identify the rhythm, whether the patient's symptomatic, hemodynamically stable, and then figure out what we're going to do for treatment. And when we look at this rhythm, this is known as SVT, supraventricular tachycardia. I've kind of done the cutesy little, well, this is atrial tachycardia. Either way, it's the same rhythm. It is a very fast rhythm that's very, very regular. And the patient is symptomatic because she does have palpitations, but she is hemodynamically stable. She is not unstable. But you don't want to keep her in that rhythm for very long, because as you could identify, this is a very fast rhythm. And if I made you run for 30 to 40 miles, you would get tired. And it's the same thing with your heart. So they can become unstable if you leave them in the rhythm for any great length of time. So what's the treatment? Well, we're going to look at all the options, because again, you have to deal with those SATAs. And so we begin that you can do the vagal movement, ask them to bear down like they're having a bowel movement. And then adenosine is the drug of choice for SVT. And adenosine is really, really the only drug that is used for SVT, or it's the only time that this drug is used. SVT is the usual drug for adenosine is the usual drug for SVT. And more than one dose can be given. If the first dose doesn't work, then a second dose can be administered. And then if the patient was hemodynamically unstable, note that synchronized cardioversion could be indicated. Any patient that's talking to you has a pulse, and that's why synchronized cardioversion could be indicated. Our next scenario is we got a 70-year-old man that presents with palpitations. The feeling began while he was on the golf course. He denies pain. He just feels like his heart is just about to jump out of his chest, and there are his vital signs. So again, we follow the questions, answer the questions, and then figure out the treatment. And when we look at this rhythm, we can see that it is atrial fibrillation, but it is atrial fibrillation with a rapid ventricular response. In other words, when you go back, you can see that there's a lot of QRSs here. So the rate on the atrial fibrillation is very rapid, and this can happen with AFib. You can get a very rapid ventricular rate, and with that rapid rate, that's what's going to give them the palpitations and can cause them to be unstable. But in this scenario, the patient is hemodynamically stable, but because the rate is so fast, we really want to either do one of two options, and that's either slow the rate down or convert the rhythm. And again, which one would be applied? Well, that's going to be a physician decision. And when we think of treatment for rapid atrial fibrillation or rapid atrial flutter, the drug of choices for this rhythm is diltiazem or cardizem. This is a calcium channel blocker that simply lowers the rate, or a beta blocker, or digoxin. So amiodarone is not listed on the sheet, but it can be given for this rhythm. So that's why I did the ABCDs. You've got amiodarone, a beta blocker, cardizem, as well as synchronized cardioversion if the patient was hemodynamically unstable, and digoxin. ABCD. Note, this is a medication tip. It's very important to note that there are some medications that convert the rhythm, and then there are some medications that simply reduce the rate of the rhythm. And when we look at two drugs, amiodarone and adenosine, these drugs are administered to convert the rhythm. They can convert the rhythm. And adenosine will do the exact same thing that a shock will do. You give adenosine, the patient will go flatline for a short amount of time, and then hopefully they will reboot, or their SA node will reboot, and they'll convert to sinus rhythm. So remember, amiodarone, adenosine are drugs that are given to convert rhythms. Now, amiodarone is kind of a dual personality. It can also be given just to simply decrease the rate. Diltiazem, beta blockers, and digoxins simply slow the rate down. And by slowing the rate down, I mean the ventricular rate. So these three drugs, diltiazem, beta blockers, and digoxin, will not convert the rate. They will simply slow the rate down. And then medications that increase the rate would be atropine and epi. We're going to continue with that same scenario of this gentleman that is in atrial fibrillation at a rapid ventricular rate. And we gave him diltiazem, and then when you return back to the room, his eyes are closed. You ask him how he feels, and he mumbles something that you don't understand. You ask him again. He still doesn't really respond very well to you. His blood pressure is diminished. His face is diaphoretic. His hands are cool, and the O2 sat alarm is going off because you've lost the waveform. So when we look at, again, it's not hard to identify this rhythm, we see that the atrial fib has returned and there is a rapid ventricular rate, and this can be the problem when you just administer medications that doesn't necessarily keep the rate slow for very long. The patient is symptomatic. They have altered mental status and signs and symptoms of poor perfusion. That is the whole cool extremities, and the loss of the O2 sat waveform is because there isn't a very good pulse. The patient is hemodynamically unstable. And so this patient needs to have rapid synchronized cardioversion. Again, the synchronized button is hit, and there will be a line or a dot or something to indicate on the R wave, and then that's when you push or when you push the electricity button, then it will hit or give the electrical impulse when it's on the working, when the heart is depolarizing, when it's working. Now we're moving on to our next scenario, a 20-year-old who's brought in by paramedics after suffering from a front car collision. His airbag was defective. It didn't deploy, which means his chest probably hit the steering wheel. He's awake and alert. His BP is marginal. Respiratory rate is 30. And as you begin a second IV, you notice that his eyes are closed and he's unresponsive and not breathing. And this is what the monitor is showing. What do we do for him? Well, first of all, is the patient symptomatic? Well, yes, he has altered mental status and he's not breathing. So as you shake and shout and you call the code, you check for a pulse and you do not feel a pulse. And with any person who doesn't have a pulse, then your next move should be to begin chest compressions, CPR. And when you look at this rhythm, if you're trying to figure out, well, what is this rhythm? Well, you can see this is sinus rhythm. But as soon as the individual lacks a pulse, that means, or that changes, that rhythm then becomes pulseless electrical activity. So you've got a rhythm that looks like normal sinus rhythm, but because the patient doesn't have a pulse, what you have in this individual is someone who has beautiful electrical activity. If you go back to the scenario, this was a young man, so that means his heart is young and it's working really well. And so the electrical activity is just fine, but the mechanical portion, the whole heart ejecting blood, is not happening. And that is why you do not have a pulse. So is the patient hemodynamically unstable? Of course he's not. He's hemodynamically unstable. He doesn't have a pulse. And so you need to do BLS. That is the basics. No pulse, you got to begin chest compressions. And here is the identification. You have pulseless electrical activity. You can see that CPR has to be administered immediately, and you have to manage the airway, giving oxygen and epinephrine. So any pulseless scenario, anytime you are doing CPR, epinephrine is the first line drug that should be given. So what else should be done for this patient? Well, you have to consider the H's and T's, because not only are these problems reversible, but if you do not consider the H's and T's, then you'll be doing chest compressions on this individual for a long time and his status will not improve. Now look at the H's: hypovolemia, hypoxia, hydrogen ion, which is acidosis, and so on, and then you have T's. So these are fixable things. So if you had this individual, let's just pretend that his airbag, when we know his airbag didn't deploy, so let's pretend that his chest smashed against the steering column. Well, this can often cause a cardiac tamponade, and this could be the reason for the pulseless electrical activity, and there is a fix for cardiac tamponade. The physician can fix this. Now, I want to just say that in addition to pulseless electrical activity, if the patient is found to be in asystole, the same treatment applies. You have to do CPR, you have to support the airway and breathe for the patient, and epinephrine is given, and then consider the causes. Now, I will go back to our original rhythm, and that's the fact that this rhythm looked like normal sinus. And I have to say that in my career, I've really only seen a normal sinus rhythm in a PEA patient. However, I have seen on multiple exams that other rhythms have been displayed, and I should clarify, other atrial abnormal rhythms have been displayed, such as SVT or atrial fibrillation. So I want to just caution you that as soon as you see a strip, and then the scenario reads that the patient doesn't have a pulse and that CPR is in progress, then your first thought should immediately go to, this is PEA. Asystole is pretty easy to identify, but PEA on critical care exams can be a little bit trickier. But know that SVT or AFib or any kind of sinus rhythm, sinus brady, then those rhythms, when there is a mention of no pulse, then that means that that is a PEA scenario for you. Again, this is just showing you the document that hopefully you're referencing. If you have asystole, it is the same treatment as PEA, and you have to consider the reversible causes, the H's and the T's. Moving on to another scenario, we've got a 70-year-old man that presents with palpitations. The feeling began suddenly while on the golf course. He denies pain. He just feels like his heart is about to jump out of his chest, and there's his vital signs. When we look at this rhythm, we can see that this is ventricular tachycardia. This is a very wide, complex rhythm, but it's very regular. It's very regular. The patient is symptomatic. He has palpitations. And when you ask yourself, is the patient hemodynamically unstable? You say, no, he's not. I mean, his blood pressure is good. He's awake and alert. Excuse me. His oxygen saturation is super good. But because this rate is so very fast, this can become an unstable rhythm. So we don't want to leave him in this rhythm for very long. But at the moment, he is hemodynamically stable. So whether the patient's having isolated PVCs or whether the patient is having stable VTAC, that is VTAC where the patient presents with a pulse and whose vital signs are stable, amiodarone is the first choice. Now, procainamide or Pronestal is also listed on that document that I've referenced all the time. So it is a secondary, but the first line drug is amiodarone. Again, here is ventricular tachycardia with a pulse. You can see the treatment scenario here. And then again, if the patient would have PVCs, then your treatment scenario is the same. And so just know that that's very similar treatment. Amiodarone is administered, the rhythm resolves after treatment, and then you continue to monitor the patient. And then an hour later, you return to his room and notice this rhythm, and you ask him how he feels, and he mumbles something, and his blood pressure is altered. He's diaphoretic. His hands are cool. His pulse is weak and thready, and the O2 sat alarm is going off. So when we re-look at this situation, we identify the patient still in the same rhythm. This is ventricular tachycardia, but he's changed. The patient is symptomatic. You have altered mental status, and you have signs and symptoms of poor perfusion. Is the patient hemodynamically unstable? Yes. The patient's blood pressure is low and he has signs and symptoms of poor perfusion. And so therefore now the treatment changes. We need to get the patient out of this rhythm very, very quickly. But because he has a pulse, we are going to deliver synchronized cardioversion. We're going to deliver synchronized cardioversion. That is the treatment of choice for ventricular tachycardia with a pulse that is unstable. And there we are here. So we have ventricular tachycardia with a pulse, and there's your treatment protocols, and we do synchronized cardioversion. He then immediately converts to a normal sinus rhythm after he has synchronized cardioversion. You continue to monitor him, and then another hour later, you return to his room and notice this rhythm. But this time, his eyes are closed, he doesn't respond when you shake, and his pulse is not palpable. So when we look at this scenario, we know, okay, now we have ventricular tachycardia. It's the same rhythm, but this individual is pulseless. And anytime there is a pulseless individual, you are going to do CPR and you're going to do your BLS scenario. And if there was a defibrillator in the room, you would actually defibrillate the patient immediately. If the defibrillator is not in the room, then you should initiate CPR until someone brings the defibrillator to you, and then you are going to defibrillate the patient. So you will defibrillate the patient. It is not important that you know what kind of defibrillator, whether it's a monophasic or a biphasic. You're not going to be asked about this. And again, the physician is going to be the one that is going to prescribe the amount of electrical impulse that's going to be delivered. You just need to know that with pulseless VTAC, you are going to do BLS, CPR, and you're going to defibrillate the patient. And because this is a code scenario, you will give epinephrine every 3 to 5 minutes. Now, amiodarone can be administered, especially if the patient hasn't had it before, but if they've had it, then you can actually double up the dose, or 1.5 times the dose. So amiodarone can be given. This is just some reminders here, is that about CPR. There are sometimes some questions about CPR. Remember the scenario for CPR, that as soon as you identify that the patient is unresponsive by shaking and shouting, then you call a code, then you check for signs of life, respirations, and pulse, and then you begin chest compressions. And this exact same recipe, treatment recipe, would be utilized for VFib. Now, notice VFib here. It's wavy, it's irregular, there isn't any pattern to it, because sometimes students do get mixed up between VTAC and VFib. This very fine VFib is just very small waves. Sometimes the waves can be bigger with VFib, but they're always irregular. It's not a regular rhythm because the heart ventricle is just quivering like a ball of jello. And so it's not going to be a very regular pattern like you see with the ventricular tachycardia. Now, the last rhythm that we're going to talk about is torsade de pointe. This is a type of ventricular tachycardia that has a very special look to it. I don't have the rhythm look or the rhythm strip for you to see because you don't have to identify torsade. It's somewhat challenging to identify. The thing you need to know is that if it has been identified, if the physician, the cardiologist, has identified that this is torsade de pointe, then magnesium IV is the treatment of choice. Again, anytime the patient doesn't have a pulse, you're going to always do CPR, BLS, and you're going to give epinephrine. But if this was identified as torsade, the drug of choice in addition to the epinephrine and the CPR BLS management is magnesium. I hope this has been helpful. If you have any questions, email me.